Hello, everyone. This is Dr. Mike Chua, Physical Therapist. Hey, today we're going to be talking about creating a successful geriatric plan of care. We'll be back in
HelloNote
a
is
few
a
seconds,
truly
okay?
therapist-friendly practice management solution with integrated EMR that will enhance workflow, efficiency, and patient care. HelloNote reduces error and allows you to spend more time with your patients. It comes integrated with billing. Claims are generated once a note is completed. You can bill with one click and a patient portal, which streamlines the patient intake process. Beautifully engineered and cloud-based for easy accessibility, the software works on all platforms. You can access patient records from anywhere. We also offer 24/7 support. HelloNote is the practice management solution that you're looking for.
We are back, and again, today we're going to be talking about how to create a successful geriatric plan of care. Let me start my. If you can hear me live, type in live. You can hear me on the replay. I'll type in replay, and then we're going to be sharing this to our team. And then again, if you can hear me, that's great. If not, let me know too. I'm just here recording in our Highland location. So, well, first of all, thank you very much for joining us in this class. And if you are from Jerry Hab, I appreciate you, and then every single one of you. Thank you very much for believing in me and doing everything what we do here in Jerry Hab. Again, let me start our share screen here. Uh, Today we're going to be talking about this creating a successful geriatric plan of care that we formulated and then created for our patients. The goal here, or the overview here, is we have four different types of phases. Okay, so this is specifically for, it could be for Medicare patient, geriatric patient. Most of our geriatric patients are they have Medicare. So Medicare Advantage plan, they are supposed to follow the Medicare standard of care. Medicare would like to, provide or tell us, hey, maintenance therapy is the way to go. You need to take care of our patients. But on that same note, we need to have a structured plan of care. No, we just don't tell, hey, okay, we're seeing the patient X amount of visits, and then we cannot justify that. So we created the structured four-phase model. First is the pain management phase. Second is the strengthening phase, and third is the balance phase, and of course, fourth is the maintenance program or phase. So you can combine the pain management, the strengthening, and balance case, and then of course you discharge that case and then create under a maintenance program. So this is obviously for PTs, OTs, PTAs, and OTAs. Um, so what are our objective? We want to understand each phases of the geriatric plan of care. What is it for? What is supposed to do? And then, of course, apply the specific techniques for each phases. We just can't strengthen someone if the patient is still hurting. We can't improve their balance if they are still weak. Let me go back again to that phases. We cannot strengthen the patient right over here if they're still hurting, and we can't improve their balance if they're still weak. How can they stand up and improve their balance if they don't have enough strength? And of course, how can we maintain them if we don't have if we didn't address the pain management, the strengthening and balance, and if they haven't reached their full functional potential? Once they reach their full functional potential, then we can keep them under the maintenance program. Hope that makes sense. So we will have to learn how to apply those specific techniques on each phases. Of course, we have to make sure we develop a measurable SMART goals. What is SMART goals? Specific, measurable, attainable, realistic, and time-bound goals. Imagine if you have a geriatric patient and we tell them, okay, let's go return to sports. Medicare will not pay for a return to sport program. It has to be a functional return to previous level of function, not return to sports. Okay, it could be a good goal, right, to their baseline level. So again, you cannot if the patient has been homebound and bedbound for a certain number of years. Let's just say a stroke patient. Why would you write a goal for 500 feet when they can't even get out of the bed? So you need to be specific and measurable and realistic about it, right? And of course, attainable. In that 12-week span, of that program, is it attainable? So some of them, their goal is going to be very small goals. So the patient will improve rolling left and right, with minimal assist from maximum assist. So you have to think about that, not just putting up a goal there that you copy and pasted. It has to be personalized. If it's not personalized and individualized, they're not going to pay for that. So we do it. We just have to write it down. Okay, and of course, last objective is to transition effectively from restorative to maintenance. We have to show in our documentation that we are trying our best. Of course, we're doing our best to transition them effectively from restorative to maintenance. Now, of course, if they're in the maintenance program and then they got sick, they need to go back, to a restorative program. I hope that made sense. So, okay, let's go next to the next slide. So, why are we doing this? Why are we doing a phased approach? Because it works. All right. Why? Because we have to have clear structures to improve our outcome. If we're not, just like writing a goal for our life, if you don't write it down, it's not going to happen. And same thing with our patient. If we ourselves don't have any goals for ourselves, it's going to be hard for us to teach patient, hey, this is your goal for your life. So, and number two, it's easier to track the progress. And of course, it's very important, the compliance part of it. And it's very important that we are compliant with what Medicare standard is. Before they didn't care, right? Okay, we're just going to see the patient forever. And nowadays, no, you get scrutinized with every single note, and each note needs to stand on its own. Okay, because the note that when they do an ADR or documentation request, they ask individual notes. They don't just check the evaluation note. They just don't check the research note or progress note. They check the random individual notes. Okay, and of course, number three, we have to be consistent for framework for all the disciplines. What does that mean? If not all, when I say not all the disciplines, let's just say the OT is under a maintenance and the PT is on a restorative. That's fine. What we're talking about here is the consistency of, okay, we're going to do a restorative plan of care, and then we're going to do a maintenance plan of care. Most of the time, PT and OT, they kind of jive together, but sometimes uh, what you call this, cross path. One discipline could be restorative because they have a shoulder issue, right, for the OT. And then, of course, with their walking and balance, they're fine. Okay, so of course, your balance is going to be affected if you have shoulder issue because you don't have that starting flex. But you know what I mean? It will cross every now and then. But what I'm talking about here in this framework here is that we all have to have that same goal in mind, that, hey, this is a restorative plan of care and this is a maintenance plan of care. Okay. Now, if you have any questions, type in on the comment section below, and I'll try to answer as much as possible. Okay, so phase one. Let's talk about phase one. Phase one is the pain management. We got to identify the source of pain first. There are plenty of therapists out there. They just go ahead and start letting them, do jumping jacks, right? Or ride the bicycle. We have to ask them their pain first. You know, you know, Common pain areas. Check the neck, check the shoulders, the scapular blade, the low back, from cervical to thoracic to lumbar to their hip and knee and ankle. So what I do, well, of course, number three is pain hinders progress. So treat it first. Treat the pain first. How can I move my body? How can I do bicep curls if my bicep hurts, right? How can I do squats if my low back hurts? So treat that first, and we have, other therapists out there. They just start putting them in a bicycle. Well, their back is still hurting, right? I mean, is that a good, clinical decision making skills? No. I mean, might as well go to a personal trainer. We are here as a therapist, whether you're a PT or OT. We have the capability to take care of their pain. So check their neck, because we got geriatric patients. If you are a geriatric therapist, okay, a gerihab practitioner or geriatric practitioner, you have to check the neck first. Okay, so you check the neck. Most of them are kyphotic. Okay, let me. So check the neck because they're kyphotic. They're like this. Their nervous system is in a fight or flight mode. Remember, you got your central nervous system, your brain, your spinal cord, your nerves, which is your peripheral nervous system. Their nervous system is in a fight or flight mode. Well, guess what? The neck is in a fight or flight mode too. That's why they're kyphotic. And then here we are, we're putting them in a bicycle or the upper body, and then you're not addressing the neck pain. Check the, not just asking them to do active range of motion. Remember, there are two types of range of motion testing. One is the passive, and the other one is active range of motion. What do you do? Oh, you just ask them to do active range of motion. A true full-blown evaluation, it will take you hours. All right. So what I do, I check, okay, you ask them to do their neck range of motion first. Can you look left and right? All right, up and down. All right, side bending. Okay, lateral flexion, rotation, lateral flexion, rotation. See, I need my neck stretches. So ask them to do that first. And then second, you do your passive range of motion, rotation. Not just like passive range of motion. Try to check the end feel. Go back to your basics. Okay, basic. What is the end feel of that specific joint? Is it a bony end feel? What are the different end feels? You got springy end feel, you got soft end feel, you got ligamentous end feel, you got empty end feel. There are a lot of end feels. If you can't remember the end feels, basically the end feeling of that joint, right? For example, the elbow, you extend it, it's bone on bone, that's a bony end feel, right? If you flex the elbow, it's muscle to muscle, that's a soft end feel. All right. If it's a ligamentous end feel, it's a ligament that you're trying to stretch. All right. If it's empty, it's pain. So that's how you describe it. Now, if you know the end feel, let's just say that it's a ligamentous end feel when you turn and rotate, right? That's a ligamentous end feel because it's ligaments that's stopping the rotation. And it's soft. When you're soft, there's something wrong. It has swelling or something, right? So same thing with the elbow. That elbow extension end feel is bony because it's bone and bone, right? And it's soft. There's swelling there. So check that out. So again, we go back to the neck, check range of motion, check passive range of motion, and check end feel range of motion too. Now, if the end feel hurts, you document empty. And then if you're a PT or OT, you address that pain. What kind of pain is it? Is it a muscular pain? Is it a ligamentous pain? Is it a skeletal pain? Is it a nerve pain? Do they have numbness and tingling sensation? So it's very important that you identify that. Just don't put them on the bicycle, right? Okay, let's go to the shoulder. We know different shoulder range of motion. Check flexion, check abduction, check internal, external rotation, all right? Check this, and then check the scapula, all right? A good therapist like you, geriatric practitioners, Gerihab, and everyone, you just don't check the glenohumeral joint. The shoulder range of motion, the shoulder joint is not just the glenohumeral joint. You also check the scapular humeral rhythm, the scapula, the shoulder blade. You also check the collarbone, the acromioclavicular range of motion too. Most of our patients, they're kyphotic. Their shoulders are elevated. Their shoulders are rounded. Their neck is forward. Well, guess what? The clavicular range of motion is elevated, right? That. And if that clavicle is up there, well, guess what? The humeral head goes in too because they're rounded shoulder. Makes sense. So check the acromial process and the clavicular too. Oh, I need my massage here. It hurts. So you gotta check that too. They have pain there. When you press, they have pain there because it's always in a fight or flight mode. Check the supraspinatus and the medial border. So when you look at the back of the back, right? The scapula, you got the shoulder blade, right? And then you got that border there on the top where the supraspinatus inserts. There's a lot of tension there. And then the medial part, the medial part of the scap. If this is the left side, the medial part of the scap, there's a lot of tension there too, where the serratus anterior, the rhomboids are inserted because their shoulders are rounded like this. So again, it's not just the shoulder joint that you need to check. The clavicle area in the scapular range of motion. Learn also the distraction technique, the open pack position. Okay, for the shoulder, you have to learn the open pack position. Why? Because if the glenoid is compacted like that on the fossa there, it's not going to move. So learn how to distract that shoulder joint. What's the open pack position of the shoulder? Uh, Abduction 80 degree of flexion 80 degrees, and then 20 30 degrees abduction like that, and that's the open pack position. You're kind of distracting it too. You're pulling it, and that way when you pull it, then you can play around with that glenohumeral joint. Then you get more range of motion. Then your patients say, oh, that feels so good. I got that, feeling of relief on that shoulder joint. So same thing at the back, the thoracic. Let's go talk about the thoracic and the lumbar area. If you're not a manual therapist, that's fine, but at least do some trunk flexion and trunk extension range of motion testing. Do some rotation range of motion testing. Just that you're doing the range of motion on that thoracic. So I asked them to do this, arms across their chest, and I just asked them to rotate actively and passively, and doing that end range of motion. They will feel a relief. They will feel a relief. That's their pain management there. Then you slowly distract them. Some of them, I don't know if you've seen me do it. I ask them to cup their elbow like this, and I just kind of carry their body up to distract their shoulder, not the shoulder, but the thoracic and the lumbar area, to release that pressure, because they're standing up all the time, right? And then the pressure on the thoracic and the lumbar area, now they have this compression, and then they always tell you, hey, I have degenerative disc disease, I have stenosis. What does stenosis mean? Stenosis means narrowing of the hole. And if there's narrowing of the hole, whether on the spinal column or on the nerve root that goes out, it's compressing everything. All right. So learn how to release those pressure. No, our body or your spine is just like a bottle of soda. When you twist and remove the cap of the soda, it releases pressure. Well, same thing with your spine. When you're distracting it and rotating it and releasing it, you release the pressure there. Okay, I'm not asking you to do grade 4 what you call this, PJM, peripheral joint mode, because that's not within our scope of practice for PTAs or CODAs, but for PTs we kind of do that. But if you can't, just do gentle range of motion, and then get the end range stretch. All right, okay. Let's go towards the. Let's go back to the slide here. Oops. How do I do that? Oh, there you go. Okay, so let's go to the hip. Same thing with the hip. You gently distract it too. Gently distract it. You can use a belt to pull the leg. We have belts that we use here. Again, what is the open pack position of the hip? It's 30-20 degrees too, on that hip area, if I'm not mistaken. On the knee, you can distract it too. 30 degrees flexion, and then you just gently distract it. The patients will complain, oh, my knee's hurting, my knee's hurting. But if I distract their knee, kind of pull their knees apart, they feel that relief. Because their knees, the femur and the tibia is compressed already. But if you relieve it and relieve that pressure, I hope you can see me with that small picture there. You're relieving that pressure, and then for some reason the meniscus kind of goes back to in place. Okay, all right. The ankle joint, same thing with the ankle joint. How many times have you seen a therapist? Let me go back to how many times have we seen therapists do some stretching for the ankle? Very rare. I mean, we see it, every now and then, but do the range of motion on the ankle, not just on the ankle joint, but also on the talar, subtalar, and on the toes itself. I forgot the hands, so we'll go to the hands. So the toes itself. If you check your patient's foot right now, I know sometimes when you you take off the socks, got all that what's all that the flurries, the snow. But if you check it, I check it all the time. Not all the time, but if they complain about the foot, their toes are already like this. They got the hallux valgus, the bunions, and they're crossing. And then we're okay, your balance is off because you don't have the reflexes. Well, guess what? Sometimes it's their foot and their toes. It's all curled up like this. We gotta address that too. We can do range of motion there. How do we do range of motion? You pull, you distract the joint into their open pack position. So when let's just say that it's just the toes, right? You distract and pull, you distract, rotate. Oh, I feel good in there. Distract, rotate. I feel that popping already. Distract, rotate, distract, rotate. Distract and flex. Distract and flex. All right. Individual toes, individual joint on the toes. The PIP, the DIP, is it PIP, DAP also called on the toes. So you do that distal interphalangeal joint, right? You distract, you pull and rotate first, pull and rotate, and then pull and flex, pull and flex, pull and extend, pull and extend. Why? Because when your foot is on the heel strike, when the heel strike and the foot flat, if they don't have enough dorsiflexion and tension of the toes, they're not going to be able to push it, and they're going to start falling backward. So it's very important that you check that too. Now let's go back to the hands. So the hands, we got patients who have tight hands. They are thick like this, right? And then they need OT, of course, right? You gotta check those wrists too. Distracting the wrist and rotate. Distract the wrist and rotate, and go to individual joint, individual carpal joints to move it. The scaphoid bone, the lunar bone, what else? All the carpal bones. Move them, mobilize it. If you're an OT, you mobilize individual joints. Use a scraping tool to scrape their thenar and hypothenar muscles, the knuckle area, right? Do some paraffin wax. Take 5-10 minutes, right? While they're doing other stuff, doing some memory stuff, therapeutic activities while are in the paraffin wax. So it's still a billable visit or minute there. And then once you remove that, do your manual stuff. Do some contract, relax, right? Get a rubber band, open that way you're managing and improve that pain level. All right. So says here, how do I share this? All right. I need to add myself here. There you go. Says here, pain hinders progress. You got to treat the pain first. All right. You got to treat the pain first. And of course, they will not come back to you. We got patients don't want to come back because they're hurting. They're already hurting, and then you hurt them more. How will they come back, right? How are they? I'm not going to come back if I was a patient. I want to feel better first. You want to feel better first so you could move better and be better, right? So let's address that pain first, okay? All right. So, here are the range of motion. Let me remove my how do I do that? There you go. So shoulder flexion in supine. Again, in supine, your scapular is your shoulder blade, your scapula is stabilized. So your range of motion is 180 and firm. Shoulder extension and prone, 0 to 60. I doubt people are going to have 0 to 60 range of motion. Abduction, 180, firm end feel. Adduction, firm end feel. Shoulder internal external rotation, they're all firm. So most of the shoulder range of motion are firm. Okay. Now, if they have empty end feel, if they're hurting, empty end feel means pain, right? Then you got to address that, right? Okay. For the elbow, again, we talked about this soft end feel on elbow flexion. Elbow extension is hard or bony end feel, pronation. is firm because it's a ligamentous end feel, right? Okay. Same thing with wrist flexion. Those are firm. Radial deviation is hard. Ooh, I felt that already. It's hard. Ulnar deviation is firm because it's ligamentous. All right. On hip flexion, look at those range of motion. Okay. I doubt some. I probably don't even have 120. So on supine, on hip flexion, soft because the quads in your abdominal area, right? Extension needs to be firm. All right. Abduction is firm, and then adduction is firm. Well, most of our patients, their end feels on this hip range of motion or testing will be empty. Most of them they're like shouting when we test them. They're straight leg racing. They're especially the hip extension and prone, especially when you flex that knee, that uh, it stretches that quads very good, and it hurts them. It stretches the quads, it stretches the psoas muscle, and then it's very tight. Their heel will not hit their gluteal area, and it's an empty end feel, and it's supposed to be firm, right? Okay, all right. Let me go back to about that. I keep on losing it. All right. Okay, where were we? Knee flexion. Knee flexion supine needs to be soft, but when, like we already talked about, if they're empty, if they're hurting, there's something going on. It could be tight. All right. Dorsiflexion, most are firm except for eversion. Eversion is hard because the lateral malleolus is hitting the talus there. Okay, but most of them are firm. So why am I telling you this? That end feel you got to know this, the normal end feel first. Soft, hard, ligamentous, firm is ligamentous, hard is bone. You need to know the normal end feel, because when the patient says, hey, it hurts, you got to address that. So let's just say the patient is prone, right? And then you flex the knee. The patient is in prone, right? You flex let's just say the right knee, and then the end feel is empty. It means it hurts. So it means the psoas is tight, and then the gastro, the quads are tight. Would you just ignore that? No, work on it. Do contract, relax. All right. If you can't remember it, ask me. We can do that too again in the future. Contract, relax. Remember your PNF, your proprioceptive neuromuscular facilitation. Do tapping techniques. Don't be afraid to tap the muscle. Right. Do some contract, relax. Ask them, hey, okay, the patient isn't prone. You're flexing the knee. Ask them to contract their hamstring, 1 2 3 4 5, and relax, and then ask them to bend it more. And then same thing in supine. If you want to do a straight leg racing and their hamstrings are tight, it's supposed to be soft when you do knee flexion and hip flexion, right, in supine. But if it's empty, if they're hurting, do PNF techniques or the contract, relax techniques. All right. So if they're in supine and then you're flexing the hip and knee, again, it's supposed to be soft, right? Because it's muscle to muscle. Now, if it's muscle to muscle, it's supposed to be soft. If they're hurting, it's empty. So do contract, relax. Ask them to press down on your hand, and then they go towards extension of the hip and the knee, and then you resist it, and then you let them go, and then you slowly flex it. And it will release. It will kind of confuse that pathway there from their brain, their muscle, and their nerves. Okay, so it's very important that you know those techniques. Okay, all right. Go to the next slide. Other pain management techniques that we're talking about. Use heat. Don't be afraid to use heat. We got in our clinic we have heat packs. Here in Highland, we still have those hot hydrocollator tanks, but we don't use it all the time because it's so high maintenance. But we just have those heat packs, those heating pads. We put it over the patient when we're trying to work on their back. We also can put it on the mat and warm their back while we're doing stretching on the. Let me highlight myself. So maximize the heat. Okay, the heating pads, those are like 40, 50 bucks that we buy at Amazon. So we put it on the back of the mat while we're stretching the hamstring, and it provides them relief, right? Or when they're in prone, we put the heat pack on their thoracic and lumbar area while we're stretching the hip flexors and the quads. So think about this: if you're providing a heat and comfort to your patient, that's good. You can also do cold, ice techniques. I don't know if you remember for the icing technique. I mean, I just used this, cold heat for chronic, cold for acute. So remember when you put cold, remember the CBAN. Okay, CBAN. You want to feel the cooling sensation first, the burning sensation, the aching, and then the numbness. Once that numbness hits, start counting 20 minutes. Uh, do icing, those ice massage. Do that too. Do that ice massage. Well, guess what? You're manually doing this to your patient. Ask them to contract their muscles while you're rubbing with ice. We're not going to get paid for the ice machine, the ice pack, or the heat, right? But if you're manually using your hand, instead of using your hand, you're using an ice cube or an ice stick or icicle or whatever. That's manual therapy. When you're stretching the muscle, you're stretching the hamstring, and then you're rubbing the ice there. You're kind of rubbing it there and putting it in there. That's manual therapy there. Okay. Do it simultaneously. You know. Next is IFC, interferential current or tense machine. You can put that on the neck and the shoulder while you put the heat. Then you do other stuff like manual therapy on the hand, contract lax on the hamstring, PNF on the low back, and so on and so forth. Okay, you just can't just leave the patient there with the IFC tense. That's a different story. But use to your advantage. Ultrasound techniques. We do a lot of ultrasound treatment, and then instead of just using the ultrasound as an ultrasound machine, use it as an ISTM tool. What is ISTM? Instrument assistive soft tissue massage technique. And then you're digging it in, and at least the ultrasound head is warm. And then you mix that ultrasound gel with some biofreeze. Oh, that patient will feel so good. All right, paraffin wax. We already talked about it. Have them dip their hand, and then have them do some uh, trunk rotation. Pelvic side to side while their hands are in that. And then after that, boom, you got that nice warmed up hand that they can move. All right. We already talked about this cervical range of motion, soft tissue massage, suboccipital release. A lot of the stress. Okay, let me uh, a lot of the stress are here on the suboccipital muscle. Learn how to distract it. Learn how to distract it. Learn how to pull that to your, help your patients to distract that. Okay, I'm gonna take off my eyeglasses here. So distract it. Go to their temple area. Right. Work on this. Forehead. Their eyebrows. Don't be afraid to touch it. We're therapists. We're physical therapists. We're supposed to touch our patient. We're supposed to physically touch the patient. Move, rotation in the eyes, rotation on the eyes, on their ears, auricular massage, auricular therapy. Grab their ears like this, auricular therapy, and they will feel so good when you're doing that. Nose, nose massage here, sinuses, right here, here. If they have stroke, teach them how to move their tongue inside their mouth, especially that if they are kyphotic, their head is forward. Ask them to keep their chin sit up straight and ask them to look up. It's going to stretch the muscle here, your hyoid bone, your SCM, sternocleidomastoid, your what's this platysmus, the muscle that covers here. Do that. Some manual techniques. Manual techniques. When I say manual, not just because you're massaging the patient, you're manually grabbing that muscle and waking it up. All right. If we don't do this, if you just become the regular person, therapist puts the patient in a new step or bicycle, you're gonna be extinct, right? We're gonna be extinct. I mean, AI is coming. They already come. They have already arrived. And if we don't become the manual therapist that we're supposed to be, adjusting and adapting to the changes, we're going to be obsolete. So we have to show the insurances, we have to show the patient, we have to show to the family that we are needed and they need it. I needed that suboccipital release. Where's that slide that we have? There you go. We need that suboccipital release, myofascial release. All right. Piriformis stretch. How do you do that? You put the patient sitting, right? Sitting down. You have them the figure of four, whether in sitting or supine, and you stretch that piriformis. Patellar mobilization. I've seen a lot of our therapists, they do this. Your knee, uh, your kneecap, your patella is like that lever that moves up and down. If it doesn't smoothly move up and down, they got arthritis, right? And you check it. I don't know if you remember the patellar chondromalacia test. And if it's positive, you got to learn how to distract that patella and then moving it up and down and helping it move up and down. And then here we are pressuring our patients. Oh, you got to bend that knee, bend that knee. But have you checked the patellar range of motion, right? IT band release. It's very important that you address IT band. A lot of people have IT band tightness. What is IT band? Iliotibial band. Okay. Iliotibial band, the IT band. What does ilio? It comes all the way to the ilium, all the way down to your tibial. And here we are, we're just stretching one body part. You got to learn how to put them in supine and then lower trunk rotation and really stretch that hip towards flexion and ask them to extend that knee and they will feel that IT band. So you're stretching. While that patient is in a stretch position, go ahead and massage and manual therapy or do the ultrasound, the IT band itself. Not just on the greater trochanter, not just on the mid part of the IT, from the ilium, right here, on the low back, from the origin all the way to the insertion to the tibia, the lateral part of tibia. And then here we are. Oh, we can't do anything about this patient. No, there are a lot of things we can do for the patient. It's just us who are not wanting to do it for our patient. Okay. So, all right, let's go back to the slide. So, IT band release. Next is neuroed. We will talk about it. Neuromuscular re-education. I need neuromuscular re-education. I need my muscle to be re-educated. All right. Postural correction. We talked about the contract relax earlier. It's very important that you do that. Posture correction. Just by giving verbal cues to your patient. Oh, put your shoulders back, Mrs. Smith. Squeeze your scapular blade. That's neuroed. Hey, tuck your chin in. Tuck your chin. Oh, I feel good already. Tuck your chin. It's going to promote better posture. That chin tucks, it's such a simple technique that when you ask the patient to do it, they'll be like, oh, that is a game changer. I feel good. I feel good on my neck. Pelvic tilt retraining. I don't know if you remember anterior and posterior pelvic tilt. Just asking them to do that 3 sets of 10, rocking it forward and back. And again, not just forward and back. When you're doing your pelvic tilting and you're sitting down, not just the forward and back motion. Do this too, side to side like this. Side to side. I'm talking about your pelvis, okay? So the pelvic tilt, posterior pelvic tilt, the anterior pelvic tilt, not just that. Ask them to do that. 3 sets of 20, 3 sets of 30. Ask them to time yourself. All right. And then forward and back like this on that pelvis. And the more you do that, the more they decrease their SI joint pain, their lumbar pain. I think I need to be doing this all the time, right? Dancing. All right. Okay. Let's go back. Where's that slide? All right. So pelvic tilt retraining. Why do we say retraining? Because we are not training the patient themselves. We are here to teach them and train them. All right. Okay. Next. Uh, of course, we're supposed to practice soft tissue massage on each other. So I want you to do that to yourself. If you are there, tense pad placement. Okay, make sure you not too close, and of course not too far. All right, and of course we gotta do the pain mapping worksheet in a minute. Okay, so next, once the pain is controlled, all right, once the pain is controlled, pain management. All right, so again, we want to talk about the the under that restorative phase, you got the pain management phase. Where did my camera go? So first phase is the pain management. You got the they can achieve. They're so good. Some people they go 12 weeks. So that's the session. Once they're ready, their pain is controlled. Then you do strengthening. This is phase two. Okay. So phase two, once the pain is controlled or under control, focus on restoring endurance and muscle performance. The strengthening part. Okay, the strengthening part. And how many times that we underload our patient? All right. So of course, I'm not telling you to overload them, but give them the right load, repetition max. Okay. So what are the strengthening things that we can do? Do sit to stand. This is a very functional exercise. You know, when I do the sit to stand, give them the modified program first. You want to set them up for success. Okay. Be you want to set them up for success. So how do I say this? Some people they want to torture the patient immediately. They want to show them, oh, you can't do this. No, set them up for success. So modify the chair, elevate the mat, add more pillows on the chair so they could go up and down. Remember, it's not about the perfection. Of course, it's all about the good movement. But if they can't move well, why ask them to do a low sit to stand? Okay, it's not testing. We're treating now. Okay, so have them go sit to stand in a higher chair. Okay, remember, this is not testing. It's about giving them empowerment. You're telling them, hey, you can do this. The more that the patient thinks that, hey, this patient is getting, oh, I'm getting better because I am able to sit to stand even though it's not perfect. All right. So give them, modify it. And then slowly but surely remove that pillow one at a time or one session at a time. Okay. A week ago, Mrs. Smith, you were able to do sit to stand 10 times with your arm pushing up on the arms with 3 pillows. That's fine. The next session, let's do 2 pillows. Oh, I was sore, Dr. Mike. Well, that's fine. Speaking of soreness, you got to remind them, hey, Mrs. Smith, you're going to hurt after this therapy, which is fine because this is how your muscle will grow. This is how your muscle gets bigger and stronger. And that's how you get better. Just like it's called muscle atrophy. It's called DOMS, delayed onset muscle soreness, right? And the more you pump your muscle, the more it gets bigger, the more you become hypertrophy, and the more that muscle gets better. And then you have to educate your patient. Hey, you're going to be sore. Now, if they're sore the following day, are you going to do the same exercise? No, make them feel good again. It could be under a pain management again, right? Okay, so let's go back to that slide. So do sit to stand, right? Do bridging. Bridging is a very, very good exercise because, first of all, they need to get out of the bed, right? They need to get out of the bed. That's going to help with the back pain too. All right. Do bridging. Do a lot of bridging. That's first. It's going to work on your glutes. Ask them to do wide base on bridging, narrow base, and then the knee flexion closer, and then knee flexion farther, or towards knee extension. That way, it will develop that gluteal muscles. Step ups. Going up and down the steps. Very good. Heel raises. Aside from heel raises, you also got to do dorsiflexion exercises. Okay, dorsiflexion exercise. Functional strengthening, bed mobility task. How many times do we ask the patient to get out of the bed? One time, two times. Ask them, hey, let's do 3 sets of 10 just getting out of the mat. I want to see you how you do it, and I want to see you how to do it again and again so you could memorize this getting out of the bed. Because most of the time, our patients, they have a hard time getting out of the bed. Me, specifically me. I have a bed cane now. Somebody sent me a bed cane to promote it. I have that bed cane. I gotta grab it and get out. Because first the mat or the bed is soft. It's hard to get out from a soft bed. And if it's not even a hospital bed, they're gonna have a hard time getting out. So it's very important. Do bed mobility exercises. They're gonna be like, oh, it sounds silly. I know how to get out of the bed. I only get out of bed one time a day. Well, guess what? When they get sick and they can't get out of the bed, they don't know how to do proper hand placement. Hand placement is the key. Improving that core muscle is the key. All right. So break down the bed mobility components. Rolling the head first, rolling the trunk, supine to sit, right? Supine to sit, rolling, putting out those leg out of the bed, right? Checking their blood pressure in supine sitting and standing too, by the way. Check that too. Orthostatic hypotension. That's very important. Okay. All right. And then next is transfers, functional training on transfers. That's very important. Okay. If you're not doing transfer training, we're doing a disservice to our patient. Tell them, hey, do sit to stand on one chair here, stand up and walk and go to the other side there. And then do sit to stand. I will do a circuit training. Circuit training. All right. Okay. Next, OTs. You got of course TheraBand. We got weights. Do some bicep and tricep extend. Not just the basic. Do functional, right? Our OTs here are amazing. He does a lot of functional activities. I see him having the patient sweep with weights in his hand, an actual weighted bar, and that patient can sweep. I tell you, functional reaching, functional grooming, right? Put some weights on their hand, all right? Folding laundry for fine motor and coordination in memory therapy too. Okay. Um, all right. Here's also what's very important too. Aside from the implementation of that implementation of your techniques, you also have to learn how to measure. All right. Use MMT, manual muscle testing. Don't make it complicated. Follow the 0, 1, 2, 3, 4, 5, the 2 minus, the 2 plus. Use that. Or also do handheld dynamometer. We I do a lot of that. They don't have to buy those expensive ones. We have those 30, 40, $50 hand dynamometer. Use that. Have them to squeeze that on their hands. Have them kick your knee extension and then resist it there. And then record the progress objectively. You got to be very objective. All right. And of course, always make sure to reinforce the patient's safety and pacing. The question is the patient able to do it, or are they safe to do it? They may be able to do it. The question is, are they safe to do it? Okay. And then teaching them activity pacing. That's very important too. All right. Okay. Number three is phase 3 is the balance. Learn how to assess and learn how to train stability. So there are different standardized tests that you can use: the Berg balance test, Tinetti tug, and then dynamic gait index or DGI. I use a lot of Berg because it's easier for me to implement. Tinetti, you can also use that. Whatever uh, works for you. Okay. Of course, also observe gait mechanics. Right? They may be able to walk. 150 feet. The question is, what is the quality of their gait mechanics, right? They may be able to walk again 150 feet. The question, how's their posture? Are they leaning forward? Are they shuffling their gait? How's their stride? Okay, so very important that you check that too. All right, your Berg, Tinetti, Tug, DGI. Okay, and this can switch back and forth from PT and OT. You just have to talk which one is which that they're going to use. Okay, all right. So again, some balance intervention that you can do. You can do static and feet together, semi-tandem, single leg. And again, that's part of your Berg balance and Tenetti test too. You can do dynamic balance intervention, cone taps, marching, reaching, and of course, gait training, stride length, the widening base of support, and trunk rotation. Not just the trunk rotation, but also the head rotation. This is where your manual therapy skills comes in too. All right. How can they improve their trunk rotation if you didn't address that on the pain management? Right. How can they stand their feet together if their feet are hurting? Okay. How can they lift one leg when the single leg stands static if their knees are hurting and you didn't distract it and decrease the pressure there? How can they march in place if their hips are tight and their backs are tight? And even the reaching, right? So address that too. And how can they lift one leg if their knees are weak, right? So make sure you check the balance intervention program that we have. So again, and then phase four is the maintenance plan of care. So once you have reached um, the goals for your pain management, the strengthening, and then the balance phase, we discharge that. If they reach their full functional potential, you create a new case under a maintenance program, and your goals will be a maintenance goal. So instead of saying patient will improve bilateral lower extremity MMT, let me take this off first. Um, Instead of saying the restore those, that's the restorative goal, the pain, strengthening, and balance, right? So in the pain, patient will improve or patient will decrease pain levels from 9/10 to 1/10 on her low back using appropriate therapeutic exercises or modalities or whatever in 6 weeks. Uh, that's the restorative. Patient will improve, patient will decrease, stuff like that. In the maintenance phase, the goals will be more of a patient will maintain current functional mobility of supervision using appropriate therapeutic exercises and modalities to prevent this patient from falling. Okay, frequency will depend upon you on the case-to-case basis. In our case, we do, let's just say, 3 times a week for the restorative. It could be twice a week or once a week for the maintenance. It could be every other week for the maintenance. It could be once a week. Or it could be once a month for the maintenance, depending on the severity of the patient. Okay, so our goal is to take care of the patient and then bring out the best in them and then maintain them so they don't fall again. Okay, all right. So the usual frequency that we use for a plan of care and the maintenance, 1 time a week, especially for MS, Parkinson's, Alzheimer's, dementia. The focus is fall prevention and independence. All right. So smart goals: maintain Berg to 45 or 56 for 3 sessions. So I don't like this goal here. Let me find another one. All right, there you go. This is a better one. Patient will maintain the ability to transition from supine to sitting with minimal assistance, ensuring continued independence in bed mobility, and then you review it monthly, right? And same thing with the transfers. Patient will sustain her capability in completing sit to stand transfer with minimal assistance, ensuring safe and proper techniques are consistently applied during transfers from bed to wheelchair, right? So you are maintaining or sustaining that patient's functional mobility. Okay, on the gait, patient will preserve her gait stability and coordination by continuing to walk 150 feet with minimal assistance while maintaining consistent pace and balance. All right, are you getting the gist of that? Same thing with the strengthening. All right. And same thing with the balance. Patient will sustain her postural stability and balance. Her maintaining her current the Berg number should be here. You know, her current maintaining her current balance score of 42 over 56 or 50 over 56. All right. So you need to put that number too. Right. Even in the MMT, you need to put, the specific MMT score. Patient will maintain bilateral lower extremity strength at current levels and assessed by manual muscle testing of 4 over 5. Okay. Or if you do dynamometer machine, patient will maintain 40 pounds per force on bilateral lower, something like that. Okay. You need to have a measurable number. This one doesn't have that measurable number. Okay. All right. So again, the transition plan, it's very important that you are evaluating and re-evaluating and admitting and discharging. So once the patient has achieved their restorative goal, which is the pain, the strengthening, and balance, and if they reach their maximum functional potential, you start a new case under a maintenance program. Now you're maintaining them, right? You're maintaining them under that program. Well, patient is maintaining it. Now, if they get sick, they get hospitalized, they fell, they got COVID, pneumonia, their dementia progresses, their Parkinson's progresses, their MS progresses. Would you keep them under the maintenance program? No. You restart a restorative phase because they're in bed for like how many days at the hospital? 3, 4 days, 1 week. They went to the nursing home. All right. You need to restart a restorative phase again and do a new reevaluation, and then showing the patient that, hey, the patient has declined. We need to restore her function and then bring her back to that maintenance program again. Don't be lazy that, oh, I don't want to do it. We have an active plan of care. No, it's very important that you do a reevaluation. When I say reevaluation, discharge the old case because the patient had an old situation and went to the hospital, and create a new one, and then do a new evaluation. Okay, in that way, you're really taking care of this patient on a new case, a new folder. Let's just say a folder that you're bringing and showing to the people, right, or to the insurance. So okay, this case here is a maintenance case. Okay, this case here is a restorative case. Okay, this case here is a pain, strengthening, and balance case. All right, and then the patient got improved. We discharged. So this case here, or this folder here, is a maintenance program. I hope that makes sense. All right, so again, documentation compliance. The frequency, normally we do 6 to 12 weeks for the restorative, and then 12 weeks for the maintenance, depending again on the needs of that patient. All right. Again, we separate the maintenance documentation for compliance. That way, we're showing the insurance people, hey, this is a maintenance program, not a restorative program. That's why we're keeping the patient longer. Because if we discharge them, they fall and they get sick, and now they're in the hospital. Remember, you always use objective data. The goals that it was showed earlier, it it's not objective. There's um, no functional mobility. There's no scores, right? You need to put the numbers there. The Berg, the Tenetti, the gait distance, the assistance level. Okay. Remember, the assistance level. I mean, the assistance level is not just a physical assistance. The assistance level needs to be. There are three types of assistance. The visual assistance, visual cues. There are different cues, right? Most of us, we know about the physical assistance, that we're helping the patient, maximum assistance, moderate assistance. But if you're still giving patient a verbal cue, a visual cue, okay, go towards that blue chair. All right, go ahead and sit on this red chair. You're giving cues, that's still an assistance. All right, if you are giving them tactile cues, all right, Mrs. Smith, you're tapping the wrist, you're tapping the hip. All right, hey, Mrs. Smith, let's go forward and go to that wheelchair. That's still an assistance. You're giving them cues. All right, okay. Where are we? All right, so always use objective data. Okay, let's do this case study real quick. Uh, 83 years old, post hip fracture with shoulder pain. So maybe the patient fell on the hip, and then she tried to reach for outstretch her hand, and then now her shoulder is hurting. What are you going to do? Are you going to start with a maintenance case here? No. Start with a restorative case, focusing on the pain, right? On, is it just on the hip? No. Take care of the shoulder too, right? And then once that pain is controlled, after a day or two or a week, then you start doing strengthening. You just can't do strengthening exercises. Help the patient control their pain. If the pain is, if they need pain medication, go reach out to the PCP. Tell the patient or family member, hey, you need to get some pain medication so we could do more with you, right? Then, so we've identified the phase, right? So pain management phase. Once that pain is controlled, then we can do strengthening, right? And then we can do balance to address that fall or whatever happened to this lady. And then we can do maintenance after that. All right. So identify the phase. We identify goals. We got to do patient will improve functional mobility or bed mobility tasks from max assist to minimal assist as a short-term goal, right? For 4 weeks. Then the long-term goal could be patient will improve bed mobility tasks from max assist to modified independent in 12 weeks, right? And then the intervention could be the bed mobility task that we talked about. All right, getting off the bed, rolling the head, rolling the trunk, sitting out edge of the bed, right? How can the patient get up if they post hip fracture? Do they have hip precautions? No bending, no twisting, no crossing. We gotta teach them that too. We gotta, and of course, how can they pull up with their shoulder if their shoulder is hurting too? You gotta address that shoulder too. Not just because the patient was referred for hip, we're not gonna treat the shoulder, right? Okay, so address those every issues. Okay, uh, go ahead and practice your bird. Write a smart goal. Right, even though you're a PTA, you need to make sure you're writing a smart goal. Why? Because you need to see if your therapist, your PTs, or OTs are doing a smart goal, right? And then discuss the discharge to maintenance workflow. So once the pain is controlled, both the shoulder and the hip, then you do strengthening, then you do balance, and then you discharge the patient from that case, and you create a maintenance workflow or work maintenance program. Okay, all right. Let's do a quick review of the Berg balance scale. I will also send you a copy of the Berg and also the Tinetti Poma, and then the scores are going to be there. So I do this all the time. The Berg, it's so easier. It's much easier for me. You just ask the patient, hey, go ahead and stand up. Try not to use your hand for support. Well, most of them, they need to use their hand. So they use their hand. Scored one, right? And then I'll say, okay, just stand up here without holding on to anything. You're just talking to them. All right. Are they able to stand safely for 2 minutes? Are they able to stand 2 minutes with supervision? 30 seconds unsupported. Just ask them to stand up. All right. Okay. Next is, are they able to sit back unsupported with the feet on the floor on a stool? Right? Are they able to sit up without any back support like this? 2 minutes without supervision. All right. Only 30 seconds or 10 seconds, and then they start falling. Okay. Next is you ask them to stand up. Yeah. If they can sit down slowly, that's good. But if they just fall backward and flop on their chair, that's not good, right? So check that too. It means they have problems with their eccentric muscle, right? They just let the gravity fall them down or pull them down, right? Okay. Transfers. Remember we talked about transfers? Arrange the chair for pivot transfer. Ask the patient to transfer one way towards the seat with armrest and one way toward a seat without an armrest. Yeah. So what I do is ask them, okay, can you stand up, move to this bed, move to this mat? You know, so in our evaluation room, we have a chair uh, with armrest, and I would ask them, hey, can you stand up and go to this massage bed or this mat and sit up for me while I check them, blood pressure and everything, right? And then from there, I can see how they move around, right? And then I'll ask them to stand up. Can you stand up for me? Both feet closed and then eyes closed. Close it for 10 seconds. All right. If they can't do it, that's not good, right? Right. Next is standing unsupported with feet together. I asked them already to put their feet together and stand without holding on to anything. Most of our geriatric patients, they're going to start, moving even with their eyes open. Right. Next will be uh, forward with outstretched arm while standing. How far can they reach? All right, 10 inches, 5 inches, 2 inches. And I would ask them, while I'm doing that, I ask them to follow that pen too with their eyes. And I would ask them, okay, can you reach and touch this pen? All right. Picking an object from the floor from a standing position. It's just very a quick test. You just ask them, hey, can you pick up your shoe? You pick up this pen in the floor, and then you'll see their biomechanic. Just by looking at their biomechanic of their reaching down, you'll know what to work on, what range of motion that you need to work on, what joint need you to stretch, and what muscle needs to be strengthened. All right. All right. Next is turning to look behind, over left and right the shoulder. Remember, it's very important that you check your cervical range of motion. How can they do this? This test here, if their cervical range of motion, their thoracic and lumbar range of motion is, you're not stretching it. They're going to lose balance. They're going to fail on this test, right? So check that too. All right. Again, turning 360 degrees. Is it less than 4 seconds? Is it more than 4 seconds? All right. And then are they getting dizzy? Note that too. All right. Are they able to put their foot on the stool while standing unsupported? All right. Can they do it for 8 steps in 20 seconds? Most of them, they can't even lift their leg up, especially this patient that we were talking about, right? She's got hip issues, right? Next is unsupported 1 foot in the front, right? Just like a tandem. Next is standing on one leg, all right? Can they hold it up independently? Some of them, they can even hold it for some of them, they're even holding up for less than 10 seconds. All right, and the total score would be 56. So this is the interpretation, 41 to 56. You just total them up, low risk for fall, right? 21 to 40, right? They need some form of walking assistance. 0 to 20, obviously, very high risk, and they likely need for a wheelchair. And then most of our patients fall over here, right? So it's very important that you do a quick test, like a Berg balance Tinetti on it. In general, less than 45 is a high risk for falls. All right. And how many patients do we see that can't do those tests, right? Okay, so let's do a sample plan of care on that specific patient that we have. That patient who fell and then hip fracture and shoulder pain. Forward shoulder raises times 2 sets of 10 reps using light dumbbell yellow, 1 time a day, 5 to 6 weeks, or 5 to 6 days per week. Shoulder raises 2 times 10 reps using light dumbbell, 1 time a day, 5 to 6 days a week. Overhead. So this looks like more like a home exercise program. Okay. Again, patient SMART goal. Patient will manage and maintain extremity pain level. So this one, they didn't say what joint. Continuously reporting pain levels at or below average of 3/10 during physical activities. It's still not specific. We need the specific joint there, right? We need the specific joint there. Again, here are the key takeaways. You got to take care of the pain first. You got to do the strengthening. You got to do the balance and the maintenance program. The pain, the strength, and the balance could be combined in one phase or one case, and the maintenance will be a separate case. Okay, you got to build the strength, build the patient. You got to measure and transition them to maintenance program. And last but not least, here is the documentation. Documentation is short protection. It's the key. Even though you have supervising PTs, if you're an assistant, you are still equally liable in taking care of the patient, and the documentation will protect you, right? We have the HIPAA scribe already, the AI to help you document properly. If you don't know that, just let me know. It's very important that you document every single intervention, you're addressing the pain, right? You're addressing the pain, you're addressing the weakness, you're addressing the balance, and of course, keeping them under the maintenance program that we're all supposed to do. If this was your mother or your father, would you want them to be under a regular maintenance program? They have Parkinson's, dementia, Alzheimer's, or frequency of falling. Yes, you would love to take care of them, right? Right. So, again, thank you very much. Appreciate you. If you have any questions, holler at me. Let me know. Ask away. Send an email. Ask questions. But again, I wish you all the best. Again, for those people, the Jerry Hab people watching, Jerry Hab staff, thank you very much for believing in us, believing in me, in taking care of our seniors. It's not perfect. We're not perfect. Nobody's perfect. No company will be perfect. No therapist will be perfect. But if our goal is to continue to take care of this patient, they will see the value in it and they will continue to come back for you. The goal is for uh, us not just to be the main provider for our seniors, but the goal is for them to that the Jerry Hab therapist uh, really believes in our patient and that they know that they will be taken care of. And imagine this: if you got your again, we talk about family members, right? Imagine you got family members. Would you bring your family members to you? I would, right? I would, because I know that we take care of our patients well. And same thing with you, whether you're watching as a geriatric staff or person who's watching through our APTA program or the CEU. Uh, would you go to yourself? No, of course you can't go to yourself, right? Would you believe on yourself? All right. Would you have you or your mom taking care of you? We got amazing therapists. I want that to be you. Again, thank you very much. We appreciate you. But before I let you go, always remember the word fast, FAST, letter F. Find people that will bring out the best in you because you are the average of the 5 people you hang out with. So find people that will bring out the best in you. It doesn't have to be me. It doesn't have to be, your coworkers. Just in your community. Find those people that will bring out the best in you. Go to your church, go to your pastor, go to the people that will bring out the best in you. Next letter, letter A, take action. All this stuff that we're doing is not going to do me good. It's not even going to do APTA good if you don't take action. Take action, implement this program, pain management techniques, strengthening techniques, balance training, and of course, maintenance program. We are the Jimmy and Sibelius case. We are supposed to be doing that for our patients. If you're discharging the patient, uh, it's different between overutilizing and underutilizing. We got a lot of people who are overutilizing, and we got a lot of people to underutilizing. There has to be a happy medium, and the happy medium is the maintenance program where you're maintaining that person, maintaining them to prevent from getting worse. All right. So take action. Next letter is letter S. Shoot for the moon. If you're shooting for the moon, you're gonna miss it, but you're gonna be landing with the stars. What does that mean? We're gonna fail. Not all patients will be applicable for this. Some patient will be good for just the pain management. Some people just want the strengthening. Some people they just want the balance program. Some people, of course, they want the whole shebang program until the maintenance. And I mean, is it applicable to everyone? No. If it doesn't work for them, it's fine. So, but you keep shooting for the moon, you keep asking, you keep serving, and you'll be fine. And last but not least, is letter T is teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, you're actually understanding it. So teach this, advocate for your patients. Tell them, hey, we're in this program right now. We're in the pain management program. You're going to hurt a little bit. We're strengthening you right now. You're going to hurt a little bit. All right. Then you'll see the balance program. Oh, my balance has improved. And then boom. You educate them. Hey, maintenance program. You go Google it. You go check. You do your research. There's a program called Sibelius, Jimmy and Sibelius, that they won against Medicare that we are supposed to provide maintenance services for your patient. All right. Again, thank you very much. Be great, excellent, and we'll see you in the next episode or the next video class that we have. All right. I'll see you around. Bye bye. And then we'll send you the recording. We'll send you the standardized test, and And of course, once you're done, we'll send you your test, and we'll also send you the different standardized tests. But make sure you do all the labs that we have, the group activities that we have. Okay. All right. Thank you. Be awesome. Be great.